Welcome back, everyone. Today, let's discuss two important topics in cardiology: cardiac biomarkers and ambulatory ECG monitoring. We'll begin with cardiac biomarkers, which provides valuable diagnostic and prognostic information in patients with acute coronary syndromes and heart failure. The most important biomarker is cardiac troponin I and troponin T. Troponins are highly sensitive and specific markers of myocardial injury. They typically peak between 12 and 24 hours after myocardial infarction and remain elevated for up to 2 weeks. This prolonged elevation makes troponins excellent for diagnosing myocardial infarction, even if the patient presents several days after symptoms onset. However, elevated troponin is not specific to myocardial infarction alone. It may also be seen in conditions such as myocarditis, pericarditis, atrial fibrillation, pulmonary embolism, aortic dissection, severe hypertension, chronic kidney disease, sepsis, respiratory failure, stroke diabetes, rhabdomyolysis, and other causes of myocardial injury. The timing of troponin measurement depends on the assay being used. High sensitivity troponin assays detect myocardial injury much earlier than the conventional assays, allowing for earlier diagnosis of acute coronary syndrome. The second important biomarker is CK-MB, or creatine kinase MB. CK-MB peaks approximately 24 hours after infarction and usually returns to normal within 3 days. Because it normalizes relatively quickly, a new rise in CK-MB after an initial myocardial infarction may suggest reinfarction. CK-MB can also be elevated in myocarditis, pericarditis, muscular disorders, cardiac defibrillation, and chronic renal insufficiency. Other laboratory markers include AST and LDH, which may increase after myocardial infarction but have low specificity and making them less useful in current clinical practice. Another important group of biomarkers include BNP and NT-proBNP. These peptides are released by the ventricles in response to increased ventricular pressure and volume overload. They are particularly useful in diagnosis and management of heart failure. Elevated BNP levels may also occur in atrial fibrillation, pulmonary embolism, and pulmonary hypertension. So clinical correlation is essential. Now let's move to ambulatory ECG monitoring. The ambulatory ECG monitoring, which records the heart's electrical activity over an extended period. This allows us to detect intermittent arrhythmias that may not appear on a standard 12-lead ECG. The type of monitor depends on how frequently the patient's symptoms occur. For patients with daily symptoms at 24 or 48 hours, sorry for that, hours Holter monitor is usually sufficient. For symptoms occurring weekly or monthly, a prolonged continuous monitor worn for 1 to 2 weeks or an even monitor is more appropriate. A continuous ambulatory monitor is a lightweight battery-powered device available as a patch or a small recorder. that continuously records ECG data for 24 hours up to 2 weeks, with the option for the patients to mark symptomatic events. For patients with very infrequent but concerning symptoms, such as unexplained syncope, an implantable loop recorder or ILR is often used. This small device is implanted under the skin in the left chest and continuously monitors cardiac rhythm for months to years. It automatically stores abnormal rhythms based on the programmed criteria or when manually activated by the patient. Another option is the external event monitor. Some devices are applied after symptoms begin and record real-time rhythm for approximately 30 to 150 seconds. Others continuously monitor but only save the ECG when the patient presses an event button. More advanced devices can automatically detect and store asymptomatic arrhythmias. Today, consumer wearable technology also plays a role. Devices such as the Apple Watch and Cardiology Mobile can record single lead ECG using wrist or finger electrode, making rhythm monitoring more accessible. The primary indication for ambulatory ECG monitoring is the evaluation of suspected cardiac arrhythmias, especially when symptoms such as palpitations, dizziness, or syncope occur intermittently. It is also useful for assessing pacemaker and implantable cardioverter defibrillator function, detecting silent myocardial ischemia, evaluating late potentials, and analyzing heart rate variability. Important points to highlight. Troponin is the preferred biomarker for diagnosis and diagnosing of myocardial infarction. CKMB is particularly useful for detecting reinfarction. BNP and NT-proBNP are valuable markers for heart failure. The choice of ambulatory ECG monitor depends primarily on how often the patient's symptoms occur, ranging from Holter monitors for daily symptoms to implantable loop recorders for infrequent events. This concludes our discussion on cardiac biomarkers and ambulatory ECG monitoring. Now, let's discuss one of the most important imaging tools in cardiology, echocardiography. Echocardiography uses ultrasound waves to create real-time images of the heart. It is non-invasive, widely available, and provides valuable information about both the structure and function of the heart. Transthoracic echocardiography, or TTE. Let's begin with transthoracic echocardiography, commonly known as TTE. This is the standard and most commonly performed echocardiogram. An ultrasound probe is placed on the patient's chest wall to obtain real-time images of the heart without any invasive procedure. TTE allows to evaluate cardiac anatomy, including chamber size and wall thickness, left ventricular systolic function, often measured by the left ventricular ejection fraction, or LVEF, wall motion abnormalities that may indicate ischemia or previous myocardial infarction, valve structure and function, the morphology of the proximal great vessels. Clinically, TTE is indicated in patients with the chest pain accompanied by the hemodynamic instability, unexplained hypotension, elevated jugular venous pressure with peripheral edema, murmurs, or syncope when the structural heart disease is suspected. It is also useful for diagnosing conditions such as aortic dissection, congenital heart disease, left ventricular thrombus, myocardial infarction complications, precardial effusion, and cardiac tamponade. Transesophageal echocardiography, or TEE. Unlike TTE, TEE requires an ultrasound probe to be inserted into the esophagus because the esophagus lies directly behind the heart. This technique provides much higher resolution images, especially of posterior cardiac structures. TEE offers excellent visualization of the left atrium, mitral valve, aortic valve, and the interatrial septum. Major indications include suspected aortic dissection when CT angiography is contraindicated or TTE images are inadequate. Evaluation of valvular disease including stenosis, regurgitation, prosthetic valves, and infective endocarditis with vegetations. Detection of intracardiac thrombi, cardiac tumors, shunts, and aortic atheromas. Assessment for left atrial or left atrial appendage thrombose before cardioversion or catheter ablation in patients with atrial fibrillation or atrial flutter. Although TE is generally safe, it is semi-invasive and carries rare risks, including esophageal perforation, gastrointestinal bleeding, and pharyngeal hematoma. Fortunately, serious complications occur in fewer than 1 in 5,000 procedures. Stress echocardiography. Stress echocardiography evaluates cardiac function while the heart is under stress. The stress may be induced by exercise on a treadmill or bicycle, or pharmacologically using medications such as dobutamine or adenosine. This test is particularly useful when exercise ECG results are equivocal or non-diagnostic. Patients have an intermediate pretest probability of coronary artery disease. Assessing myocardial viability after an acute coronary syndrome to determine whether revascularization may be beneficial. Evaluating the severity and clinical significance of valvular heart disease. Investigating left ventricular dysfunction, pulmonary hypertension, hypertrophic cardiomyopathy with left ventricular outflow tract obstruction or unexplained syncope. For patients who cannot exercise, dobutamine stress echocardiography provides a valuable alternative. Low-dose dobutamine can also assess myocardial viability and evaluate severe aortic stenosis in patients with reduced left ventricular systolic function. Stress echocardiography has contraindications. Absolute contraindications are similar to those for exercise stress testing. Dobutamine stress testing should be avoided in patients with tachyarrhythmias or severe systemic hypertension. Relative contraindications include abdominal aortic aneurysm, electrolyte abnormalities, left main coronary artery disease, and moderate stenotic valvular disease. Contrast echocardiography with agitated saline. Finally, let's discuss contrast echocardiography using agitated saline, often called the bubble study. In this technique, agitated saline containing tiny ear microbubbles is injected intravenously. These bubbles improve visualization of intracardiac blood flow and help detect abnormal right to left shunts. The most common clinical applications are identifying a patient's foramen ovale, or PFO, and detecting intrapulmonary shunts. In a normal heart, the microbubble remains within the right side of the heart before being filtered by the pulmonary circulation. If bubbles appear in the left heart shortly after injection, this suggests the presence of an abnormal shunt. Important points to highlight. Transthoracic echocardiography is the first-line non-invasive method for assessing cardiac anatomy and function. Transesophageal echocardiography provides superior visualization of posterior cardiac structure and is especially useful for evaluating valves, thrombi, and aortic diseases. Stress echocardiography assesses ischemia, myocardial viability, valvular disease, and physiological or pharmacologic stress. Contrast echocardiography or bubble study is primarily used to detect intracardiac and intrapulmonary shunts. Understanding the strength and indications of each echocardiographic technique is essential for selecting the most appropriate diagnostic test and optimizing patient's care. Now let's discuss exercise stress testing. One of the most commonly used non-invasive investigations in cardiology for evaluating patients with suspected coronary artery disease. An exercise stress test is a cardiovascular stress test performed using a treadmill or a stationary bicycle while continuously monitoring the patient's electrocardiogram, heart rate, and blood pressure. The goal is to detect inducible myocardial ischemia, identify exercise-induced arrhythmias, evaluate symptoms such as chest pain or shortness of breath, and objectively assess exercise capacity. The results of exercise testing help classify patients into 3 risk categories. Patients with low-risk findings can usually continue with medical therapy without invasive testing. Those with intermediate risk findings often require additional evaluations such as stress imaging or coronary angiography. Patients with high-risk results should be referred promptly for cardiac catheterization because they are more likely to have significant coronary artery disease. Indications. Exercise stress test is most useful in patients with an intermediate pre-test probability, roughly 10 to 90%, of coronary artery disease based on age, sex, and representing symptoms. It can also be useful in patients who already have mild baseline ECG abnormalities, such as less than 1 millimeters of ST depression, left bundle branch block, digoxin therapy, or estrogen use, although interpretation of STG segment changes may become more difficult. Importantly, the value of the test extends beyond simply looking at ST segment changes. Prognostic information comes from exercise duration, functional capacity, heart rate recovery, blood pressure response, symptoms during exercise, and the occurrence of arrhythmias. However, remember that exercise stress testing is not a perfect diagnostic test. Both false positive and false negative results can occur. So findings must always be interpreted in the context of patient symptoms and overall clinical picture. Absolute contraindications. Exercise testing should not be performed in patients with acute myocardial infarction within the previous 2 days, unstable angina, uncontrolled arrhythmias causing hemodynamic instability, symptomatic severe valvular stenosis, uncontrolled symptomatic heart failure, active endocarditis, myocarditis, or pericarditis, acute aortic dissection, acute pulmonary or systemic embolism, or any serious non-cardiac conditions that could worsen with exercise. These situations increase the risk of serious complications during stress testing. When should the test be stopped? The test should be terminated immediately if the target heart rate has been achieved, the patient wishes to stop, there is a drop in systolic blood pressure greater than 10 millimeters of mercury despite increasing workload, especially if accompanied by evidence of ischemia. Moderate to severe angina develops. Significant ST segment elevation appears in leads without previous Q waves. The patient develops neurological symptoms such as dizziness, ataxia, or near syncope. Signs of poor perfusion, including cyanosis or pallor, occur. Technical problems prevent accurate ECG or blood pressure monitoring. Sustained ventricular tachycardia develops. Remember, patient safety always takes priority over the completing the protocol. Risks. Although exercise stress testing is generally very safe, complications can occur. Rare risk includes myocardial infarction, serious arrhythmias, hemodynamic instability, orthopedic injury, and very rarely death. Fortunately, the risk of major complications during supervised testing is less than 1 in 5,000 to 10,000 tests. Common treadmill protocols. The Bruce protocol is the standard treadmill protocol. It consists of 7 stages, each lasting 3 minutes, with progressive increases in both speed and incline. For elderly patients or those with limited exercise capacity, modified protocols such as modified Bruce or modified Norton protocol are often preferred because they begin at a lower workload. Duke treadmill score. An important prognostic tool derived from the exercise stress test is the Duke's treadmill score. It incorporates exercise duration, maximum ST segment deviation, and exercise-induced angina. The formula is the Duke's treadmill score is calculated by taking the exercise time, subtracting 5 times the segment deviation, and then subtracting 4 times the angina index. where the angina index is 0 for no angina, 1 for non-limiting angina, 2 for exercise-limiting angina. Interpretation is straightforward. A score greater than +5 indicates low risk with excellent prognosis. Scores between +4 and -10 indicate intermediate risk. Scores below -11 indicates high risk and are associated with significantly increased mortality. Finally, patients who have normal stress imaging studies, whether nuclear perfusion imaging or stress echocardiography, generally have an annual risk of death or non-fatal myocardial infarction of less than 1%, making these reassuring results that often avoid the need for invasive evaluation. Important points to highlight. Exercise stress testing is a simple, inexpensive, and valuable first-line investigation for suspected coronary artery disease. It provides not only diagnostic information, but also powerful prognostic data that guide further management and risk stratification. Let's begin with the nuclear cardiology. Myocardial perfusion imaging, or MPI, is commonly performed using ECG-gated single-photon emission computed tomography, also known as SPECT. This technique uses a radio-labeled tracer that is taken up by viable myocardial tissue. The major advantage of MPI is that it allows us to evaluate myocardial viability, detect myocardial ischemia, assess myocardial perfusion, and simultaneously measure left ventricular function. It also provides important prognostic information by predicting the patient's future risk of cardiac events, independent of their history, physical examination, resting ECG, or stress ECG findings. This test is often referred to as MIBI scan because the commonly used tracer is technetium 99 and system-MIBI. Another tracer that may be used is thallium 201. Although technetium-based tracers are more common today because they provide better image quality and lower radiation exposure. The study consists of two sets of images. One is obtained during stress and the second is acquired at rest approximately 3 to 4 hours later. Stress can be induced either by exercise on a treadmill or by pharmacologic vasodilators such as dipyridamole, adenosine, or regadenoson. Indications of MPI. MPI is useful for diagnosing coronary artery disease, especially in patients presenting with possible acute coronary syndrome who have a non-diagnostic ECG and negative cardiac biomarkers. Exercise MPI is particularly indicated when the resting ECG cannot be interpreted accurately, such as in patients with left bundle branch block or significant baseline ECG abnormalities. It is also useful for patients with an intermediate pretest probability of coronary artery disease who have normal or equivocal exercise ECG results, and for patients whose symptoms have changed since previous cardiac imaging. When patients are unable to exercise or cannot safely discontinue medications such as beta blockers or calcium channel blockers, pharmacologic stress MPI is preferred. Whenever possible, however, exercise stress testing remains the preferred method because it provides additional information about functional capacity. Contraindications and risks. There are important contraindications to remember. Pharmacologic vasodilators such as adenosine, regadenoson, and dipyridamole should not be used in patients with hypotension, sick sinus syndrome, high-grade AV block without a functioning pacemaker, or reactive airway disease because these medications may worsen bronchospasm or conduction abnormalities. Pregnancy is also considered a contraindication because of exposure to ionizing radiation. The main risk associated with nuclear cardiology studies is radiation exposure. Although the dose is generally low and considered acceptable when clinically indicated. The stress echocardiography. In here, it briefly mentions stress echocardiography, which combines exercise or pharmacologic stress with echocardiographic imaging to detect stress-induced wall motion abnormalities. Unlike nuclear imaging, stress echocardiography does not expose patients to radiation and is discussed in greater detail in the echocardiography section. Cardiac catheterization and angiography. Now let's discuss right heart catheterization, also known as the Swan-Ganz catheter or pulmonary artery catheterization. This invasive procedure measures pressures within the right atrium, right ventricle, pulmonary artery, and pulmonary capillary wedge position. It provides valuable hemodynamic information including cardiac output, systemic vascular resistance, pulmonary vascular resistance, mixed venous oxygen saturation, oxygen delivery, and oxygen consumption. These measurements are especially important in critically ill patients and those with complex cardiovascular disease. Cardiac index. One important measurement obtained from right heart catheterization is the cardiac index or CI. Cardiac index equals cardiac output divided by body surface area, providing a more individualized assessment of cardiac performance. A normal cardiac index ranges from 2.6 to 4.2 liters per minute per square meter. Values below 1.8 liters per minute per square meter usually indicate cardiogenic shock and severe impairment of cardiac function. Pulmonary capillary wedge pressure. Another key measurement is pulmonary capillary wedge pressure or PCWP. This pressure is obtained by advancing the catheter into a small pulmonary artery until it wedges. In the absence of pulmonary venous disease, the PCWP closely reflects left atrial pressure, making it an indirect estimate of left ventricular filling pressure. Indications. Right heart catheterization is indicated in patients with unexplained shock or uncertain volume status, severe cardiogenic shock, including suspected acute valvular disease or cardiac tamponade, known or suspected pulmonary arterial hypertension, Patients with complex congenital heart disease, left to right shunt, severe valvular disease, or pulmonary hypertension who are being evaluated before corrective surgery. Contraindications. The contraindications include local infection at the catheter insertion site, the presence of a right ventricular assist device or RVAD, placement during cardiopulmonary bypass where catheter insertion is generally avoided. Summary. To summarize, nuclear cardiology using SPECT myocardial perfusion imaging is a powerful non-invasive tool for detecting myocardial ischemia, assessing myocardial viability, evaluating left ventricular function, and stratifying cardiovascular risk. In contrast, right heart catheterization is an invasive hemodynamic study that provides direct pressure measurements and assess cardiac performance in critically ill patients, pulmonary hypertension, cardiogenic shock, and complex structural heart disease. Understanding the indications, contraindications, advantages, and limitations of these diagnostic modalities is essential for selecting the appropriate test and optimizing patients' care. Thanks for watching. If you're new to the channel, please don't forget to like and subscribe and press the bell icon. See you in the next lectures.